Good morning. Today I will be doing critical appraisal of a guideline. So first we will start with a case scenario. This is a 70-year-old woman. She is a diabetic and has ischemic heart disease. She is 25 years post-menopausal and with a FRAC score, fracture risk assessment tool, of 70%, which means that she has a 10-year risk of an osteoporosis related fracture of 70%, and she's come to your OPD. You've read that there are few therapies, anabolic therapies like romosozumab, which is a monoclonal antibody, or teriparatide, which is a PTH-related peptide. But you have few concerns because romosozumab is contraindicated in patients who have a history of MI, and teriparatide requires refrigerator storage. You want to know if there are other therapies, other anabolic therapies prior to giving bisphosphonates, which you can use for this patient. And after a search, we come across this guideline, which is namely Abaloparatide for treating osteoporosis after menopause.
Isn't that institute I was telling you about? NICE is the UK institute. So.
This is what the recommendation says. Abaloparatide is recommended as an option for treating osteoporosis after menopause in women, trans men and non-binary people if they have a very high risk of fracture. They have defined very high risk of fracture as above 60% FRAC score. But they have also said that it is only recommended if the company provides it according to the commercial arrangement, which they have an agreement with the company, the pharmaceutical company is Theramex. They have also mentioned that if people with the condition and their doctor consider these to be suitable options, namely Abaloparatide, romosozumab and teriparatide, after discussing the advantages and disadvantages, the least expensive suitable treatment should be used. So this is what the guideline says. Now we'll use this tool, the APPRAISAL tool, which is used for critical appraisal of a guideline to see how robust this guideline is. So APPRAISAL is used to assess guidelines developed by either local, national or international groups, and it is used for the following state. It can be used by the following groups like healthcare providers who want to apply it to their practice, or for guideline developers or policy makers, and educators like ourselves for critically appraising. This tool has 23 key items and it's organized within 6 domains followed by 2 global rating scales. So the domains that this tool uses are: one is the scope and purpose, which is the overall aim, the health question. We look at these in detail. The next is the stakeholders. How many stakeholders have they, whose opinion they have taken into consideration before making this guideline. The next is the rigor of development. Have they looked at all the evidence and have they analyzed it before making this guideline. The next is the clarity of presentation. How they have presented this guideline for use. The following that is applicability. Have they considered barriers to its use and facilitators. The next is editorial independence, which we look at conflict of interest. After this, they have provided an overall assessment where, based on the score that we provide across these 6 domains, we will give an overall assessment and whether, as Sir said, we can adapt, adopt or develop a new guideline. Coming to the first domain, we are looking at scope and purpose. The first question is, has the overall objective of the guideline been specifically described? For this, we want to look at what the health intent is. They have written it. They have written that Abaloparatide can be used as a treatment option for postmenopausal women with osteoporosis. So the health intent has been written clearly. The target population they have mentioned, again, postmenopausal women with high risk of fracture, very high risk of fracture, which is more than 60% of FRAC score. But what is the expected benefit? Like how much over a period of how many years, how many fractures can be expected to be reduced, or what is the quality of life benefit? They have not clearly mentioned in this guideline. The comparison again is not mentioned in the first sentence. They have just written it as Abaloparatide can be used as a treatment option. But as compared to romosozumab, teriparatide, is it better, or in what population it can be used? Again, not very clear from this guideline. So that's why from 7 is the highest score. I have downgraded it by 1 to give a score of 6 for this question. Coming to the second question, the health question is specifically described. For the health question, we want to look at the population, intervention, comparator and outcome, including health setting. So the population in the guideline, I have just quoted this population that they mentioned: women, trans men and non-binary people who are registered female at birth after menopause with a FRAC score of more than 60%. So the population has been clearly mentioned. The intervention they mentioned as abaloparatide followed by alendronate. Again, in the guideline sentence, they have just mentioned abaloparatide. They have not mentioned the treatment duration also. All this is in the subtext, which is the big document that you have to read to find out for how many months you have to give it. The comparator is romosozumab or teriparatide, which is followed by alendronate. Again, the duration of each is not mentioned in the guideline. The outcomes are, the outcome in the guideline per se is not specifically mentioned. They have not said this will reduce osteoporotic fragility fracture. They have just mentioned it. It can be recommended for people with high risk of fracture. But the outcomes they have looked in the evidence is osteoporotic fragility fractures like vertebral, non-vertebral, hip fractures. They have looked at adverse events and health-related quality of life. But these have not been specifically mentioned in the main recommendation per se. They mentioned that the reason for looking at this option is teriparatide requires refrigerator storage and romosozumab is contraindicated in patients with MI and stroke, which is why they want to give another option to the public. Again, the healthcare setting, who can use it, like endocrinologists, primary, secondary, tertiary care, has not been mentioned. The dosage has also only been mentioned in the committee papers. It's an 80 microgram once daily subcutaneous injection. That's also not mentioned in the main guideline. Which is why I have downgraded this again by 1 to 6 to answer this question. Coming to the third question, we want to know whether the population to whom the guideline is meant to apply is specifically described. We've already seen the population. They mentioned postmenopausal women with very high risk of fracture. But what is the age range? Whether they have prior fractures, what comorbidities can they have? Whether we need to exclude any population when we are applying this has not been mentioned specifically. If you are looking at the evidence, the active trial was one of the RCTs they looked at to frame these guidelines. And that mentions postmenopausal women aged 49 to 86 years with a T-score cutoff with prior fractures. So in the evidence, they have clearly looked at a particular set of population, but that has not translated to the recommendation that they developed. So these seem quite broad when they say postmenopausal women with high risk of fracture. So I have downgraded the population, the score that we give for this question. So we finished the first domain, which is we are looking at the scope and purpose of this guideline, and we've given scores for each of these three questions. Coming to the second domain, we want to look at stakeholder involvement. So the first question is, the guideline development group includes individuals from all relevant professional groups. So here we want to look at who are the members of that guideline development group. So we need subject experts, we need health economists, we need epidemiologists, and we need patients also who have this particular condition to give their own inputs. So we can see that there are 25 members, of which there are subject experts, there are health economists, there are epidemiologists, there are trauma specialists. So they have included a wide range of people. There are patient experts as well, which we'll come to subsequently. But so they've mentioned each member's role. So with regards to the subject experts, where they are working, what is their qualification, that has been mentioned specifically in the committee papers. But what is their individual role in developing the guideline? What did they contribute to in each part of the guideline has not been mentioned. So that is not very great in this guideline. If you come to so for this question I have again downgraded it by 6 because they have not mentioned the members' role in developing the guideline per se. Coming to the next question, the views and preferences of the target population have been sought. Here we want to know whether patient preferences or patient important outcomes have been taken into consideration before developing this guideline. So they mentioned that they have consulted with various patient groups. Like these are the patient care and action groups that they have looked at. And they've also taken expert personal perspectives from these people who are suffering from postmenopausal osteoporosis. These patients, experts are however nominated by the Royal Osteoporosis Society. So we would like to know if the Royal Osteoporosis Society is funded by the pharmaceutical, because then that might change the patient perspective. Looking at their funding, they have mentioned that the pharmaceutical, which is Thambu, has not supported them in the last 12 months, but they might support them later in 2023. So again, that is something that we found while looking at this guideline. So I have downgraded that by 6 for this question. Coming to the next question, target users of the guideline are clearly defined. So this has not been mentioned clearly. By target users, we mean who is going to apply the guideline. Is it primary physicians or specialists, endocrinologists, or doctors at which level, tertiary, secondary, primary. They've just mentioned it as healthcare professionals can apply this guideline. They should have also mentioned who their intended audience is, how they may use it. So again, downgraded that to 2 because it's not mentioned clearly at all in the guideline. Coming to the third domain, we are looking at rigor of development. Here we look at what is the evidence and have they looked at it and analyzed it before making the specific guideline. So coming to the question, systemic methods were used to search for evidence. So the clinical evidence that they have looked at is one RCT, which is an active trial, including the active extended, which they have taken it for an extended period of time. This is an RCT which looked at Abaloparatide, which is our drug, versus placebo, or Abaloparatide versus teriparatide. They've also looked at an observational study which looked at Abaloparatide versus teriparatide and a systematic literature review and network meta-analysis. So they've considered considerable they've done quite a good search and come up with these evidence. We look at the how good the evidence was. Coming to search terms, they have only looked at English language studies. This is for the systematic literature review. The search was conducted in April 2023. And when they did this initial search, they included only studies which were published after 2012. But later in November, they wanted to include studies before 2012 as well, so they did another search. So ultimately, they've included records without any given specific time cutoff. And we can see that they've looked through PubMed, Embase, Cochrane, and clinicaltrials.gov. They've looked at conference articles, and they've come up with 15 records which they included in the feasibility assessment of the network meta-analysis, of which they've included 25 in the network meta-analysis. Another thing is the active trial, which is the RCT that they looked at. They've said that they took the data from the active trial not from the publication but from the clinical study report, which is the report that they've taken from the publication but excluding 2 sites. Reason for why they excluded those 2 sites is not mentioned. Again, they've said that active trial data taken from the CSR is excluded, but it when we look at it, they have included the study as well. Active trial excluding sites 131 and 132. So they in fact included it in the network meta-analysis. So while there is some discrepancy, they have done an overall search to look for the evidence. So I have downgraded by just 1 to 6. Coming to the next question, criteria for selecting the evidence. We want to look at inclusion-exclusion criteria. So this is with regards to the literature review. They've included postmenopausal women at high risk of fracture, and they've defined what they mean by osteoporosis. So the inclusion-exclusion criteria for the systematic literature review are given clearly. The eligibility criteria for inclusion in the network meta-analysis has also been given clearly. So we are happy with this part of the critical appraisal. So I have given a score of 7. They have described the criteria of selecting evidence clearly. Coming to the 9th question, the strengths and limitations of the body of evidence are clearly described. So they have mentioned they have, so the first thing is the company submission. The company submits a proposal to NICE, followed by which an external assessment group reviews it. So the active trial data as per the company submission has low risk of bias, which is the RCT that they use to get the evidence from. But the external assessment group says otherwise, that it has a high risk of bias since they had a high attrition. So there was a discrepancy in that. But they have given the risk of bias for the RCT and the systematic review. They have looked at adequate outcomes, new osteoporotic fractures, vertebral, non-vertebral, hip fractures. They have done a network meta-analysis. They have given heterogeneity by I-square, and they have reported adverse events as well.
So for the PGs to learn, the same questions every Saturday we do. Randomization, allocation, baseline characteristics, blinding, dropout, intention to treat. The same question we ask me every Saturday. So that's what you learn now is exactly what the whole world does. That is the when a pharmaceutical company does study, they have a 100 or 500 page document on the entire where they got the drug, how it is done, everything. That's called a clinical study report, CSR. They never share that. But they have to share that with the government of India. Government of India is going to give permission. They would publish that. So these people have got that CSR. Then when you publish something, you publish the RCT. That's got the same kind of question which these people have used. Nice. Randomization, allocation, prognostic. The pharmaceutical company has rated themselves very high. You have done a perfect study. Just look at the second item. Was allocation concealed properly? No. So he would have put that. Now the current risk of bias is called risk of bias 2. Allocation concealment is even more higher considered than randomization itself. I can say I know the random order. Treatment, no treatment, no treatment, no treatment, treatment. But if I know the order, and Niven walks in, Niven is treatment route, Niven looks very frail. Niven, why don't you go have coffee and come? Why? No, I'll buy you coffee. When you Niven goes for coffee, Dr. Vignesh comes, he looks very healthy. You are the number one patient. So what happens? Subconsciously or subtly, I can start manipulating the order in which patients come. And slightly sicker patients are pushed to the control arm, and slightly healthier patients, this may not be picked up in the baseline characteristics. But as a doctor, you know, you have a hunch who's going to do well and badly. The allocation considered not done properly, that's a big thing. So the pharma companies had everything perfect, but they were able to pick up that. So I'm just trying to say, what we teach you every Saturday, learn that well, because one day you'll be making that work.
Even for the systematic review, they have looked at all these questions and they have given the risk of bias or the answers to these questions for all the 25 trials that they have included in the network meta-analysis.
Let's go to the previous one. This is something which we learned yesterday when we were doing risk of bias now. People are like, hey, the world is not black or white. Was randomization done in our Saturday appraisals? We say yes or no. Now we say yes, probably yes. Let's see that one below that, question 1 ran. Yes, no, not clear, not available. So there is risk of bias. Now they say yes, probably yes, no, maybe no, or not clear. Not clear means just put one word randomization. I can't make out how they did it. They use the word allocation, but I can't make out how they did it. They put not clear. So you can give a little more nuanced view of critical appraisal nowadays. But currently we should be a little more strict. If you didn't describe it in the current sense, you are a highly trained researcher. Why would you describe it? We should say one extra line, we did it by this method. So that's why this is a very important thing for people to learn. Okay.
With regards to findings of the network meta-analysis, they have not published it saying commercial agreements, so they cannot put it out. So they have not published the network meta-analysis finding, but they have given the findings of the active study and the real world analysis. So, but they mentioned that the network analysis had inconsistent results, but they have not mentioned exactly what the result was. So that was again, I've downgraded the score for this question by 1 to 6.
Once a study is published, the data is in public domain, then the company cannot say, you can't use our data. So they could have used the published data in the network meta-analysis. Maybe they had in the company report, which is confidential, some data which the company did not want. So you have to read between the lines. If the company's data was very good supporting its own drug, why would it say you can't publish it? They will in fact say, please take, put it. The fact that they're telling you can't use this data, I'm not saying you will cast aspersions on their character or say that they will, no, they're not. Without pharmaceutical company, we can't survive as doctors because we'll make drugs for us. We'll be still doing, maybe only lifestyle. There's nothing wrong with that, but still. But same time, always start with the perspective that, hey, there may be some conflict of interest going on, and I may land up with the wrong answer. So let me just be careful. I would view that black box as with 2 horns, like, hello, something's up here. Somebody else will tell you, no, don't suspect the pharmacy. But my own bent of mind is that that's a big red flag. So you put it down to 2. I also would agree.
I just reduced by 1.
Okay. I would have done it by 2. But the advantage of Agree 2 is it's an online tool. Each question, whatever grade you give, it will give an explanation. You may disagree and say, no, how can you do that? Put it up. But it's transparent. So somebody else looking at the critical appraisal or guideline will say, I don't agree with you. Put it up by 1, put it down. But just like systematic review, everything has to be transparently reported. Because ultimately it's my opinion. But guideline is not developed by me. There's a team of people. So at the end of it, we'll see that for every single one of these decisions, the team votes. And then they'll keep voting. Like go back. So you will vote and say that, no, I'm going to put that as 6. Or I'll put this as yes, no.
till we come to an, and then we'll even record and say that if we had a difference of opinion, so many number of people. Previously it would be an unblind, like all of us sit together. And whatever I say, everybody will agree. Now it's blinded. But now with Zoom or some other technology is very easy. You can have a vote and nobody knows who did the vote. That is equal vote for all members. So, and you can even document. This was the vote, this was the agreement. On this particular item, there was no agreement. It was 5 to 4. Then okay, then you realize that okay, these are tricky decisions. Or this was 9 to 1, means that most people seem to agree with that kind of decision.
Coming to the next question, the methods for formulating the recommendations are clearly described. They should have mentioned how they reached a consensus with the Delphi technique, how voting took place, how it influenced the recommendations, but that has not been given clearly. But when we looked at the NICE guideline making process, there are some generalized guideline development process flow which has been given, which is mainly they look at provisional appraisal topics, they identify the stakeholders and they prepare a scope. Then they look at these topics and they submit the evidence, after which an external assessment group reviews it again and makes a report. And then further which the committee papers, which is the committee that's making the guideline, prepares these papers, goes through an evaluation committee and drafts the guidance and the guidelines issued. So in short, there is a submission by the company to the government, following which an external assessment group reviews that submission, and both of these are taken into consideration by the evaluation committee for making the guideline. But for this specific question, how they reach the consensus for this particular recommendation, what was the voting process, has not been mentioned in clear. So that's why I have downgraded it to 2. Coming to the next question, the health benefits, side effects and risks have been considered in formulating the recommendations. So they have mentioned, as we've already seen, this is the data from the active trial. It shows a benefit that abaloparatide reduces the risk of new vertebral fractures versus placebo. There are also data to show that abaloparatide versus teriparatide in the network meta-analysis, again the results are not given, but in the real world study and in the RCTs it has shown a benefit in reducing as compared to placebo. And looking at adverse events, they have also mentioned that these were the adverse events. It was 90.3%, that was the all treatment emergent adverse effects. But with comparison to teriparatide, it reduced the incidence of hypercalcemia was less as compared to teriparatide. It was 6% in teriparatide while it was only 3.3 in abaloparatide. So they mentioned these documents in the committee papers. So they have given the health benefits, side effects. I have downgraded by 1 because again the network meta-analysis results have not been given in the committee papers. Now coming to this question, there is an explicit link between the recommendations and the supporting evidence. So we would like to know at first glance whether the recommendations are based on good evidence. So these are the recommendations. Ideally they should have graded it saying strong recommendation or conditional recommendation, but they have not given that. They should have had a link or a superscript leading to evidence tables or evidence summaries. The previous table was given in a particular link which is there in a corner of the committee papers. So it's very difficult to find the evidence. So for someone who wants to use this drug, it should have been given more clearly as to what is the strength and what is the evidence tables for recommending this drug. So that has not been given, which is why I have downgraded it to 1. The guideline has been externally reviewed by experts prior to its publication. So as we've already seen, there is an external assessment group. This group was the Sheffield Center for Health and Related Research. They've externally reviewed this and the reviewers and their affiliations have been described. There is no conflict of interest in this particular group. They mentioned their key findings and the evaluation committee has taken the findings of this committee also to make the recommendation.
There is an important point which I did mention earlier. Suppose Association of Physicians of India commissions you to make a guideline. And there's a journal, JAPI, Journal of Association of. Once you make the guideline, what do? You have made the guideline properly, we just publish it. But suppose me and Dr. Vignesh make a guideline, which they didn't ask us to, and we submit a guideline to the journal. What will the journal do? They will submit it to 2 external reviewers to review it. The problem here is, the Association of Physicians of India, which runs a journal JAPI, has asked David, a member of API, to make a guideline for itself. So usually they don't send that for external peer review. Or if they do send it to external peer review,
They'll send it to Sakshi and say, Sakshi, you're also our friend, like, you're also a member of API, please review it, and you will give some nonsense comments, so put one comma here, put one capital here, and then, okay, some corrections were made. So that external peer review is a big deal. Who was this group? Were they truly external to this nice other thing? What was their conflict of interest? Because everything is now dependent on them saying that this guideline was well developed. 99.9% of doctors will just say, nice, send you Abaloparatide, give it. Because now it's free, it's available in the UK health system. You come with severe fractures, you take Abaloparatide and go. And that is charged to the UK health, your tax is paying for that. So you're also very happy. So that everything depends on that external agency saying the guideline was well developed. So we have to know about this sharp group.
They've given each of their members and their conflict of interest,
okay.
And it's
okay. So there are two types of conflict of interest. What are they? Financial conflict of interest is very easy. Do you have shares in the company which produced Abaloparatide? Second is called academic conflict of interest. If you see, most of these drugs are not developed by pharma companies. That's again a shocking truth. They are developed by these young researchers in universities. Those universities' salaries are paid for by taxpayers' money. They're usually poor people, and the universities are filled up bright young people. They do some basic science research and develop a molecule. These pharma companies are looking out, they don't spend any money, they say we claim millions of dollars. Okay, this is my slightly socialist viewpoint, but it is true. They will be scouring pharma university colleges. What are the drugs those guys are finding out? Because you have done the hard work and you have studied a lot and finally found out that Abaloparatide. They will come to the university, let us say Sheffield University. Hey, this nice molecule you have, you want to buy it from me. What do you mean buy it? Hey, you take 100,000 pounds. Man, our whole budget for 5 years is 20,000 pounds. You are giving 100,000. But once you buy it from you, then you can't say it belongs to you. Everything belongs. Then they'll say it was developed by GlaxoSmithKline. And they'll give a number. Nobody knows that actually developed from here. So, the universities also now will come up with a thing. They're a little bit smart. No. For every time you sell Abaloparatide, give us $1. So now you have an academic conflict of interest. So now the paper will be sent to Sheffield University for review. Then they will want Abaloparatide to show up well because now they have a conflict of interest. So academic conflict of interest could be another way. I spent my whole lifetime developing Abaloparatide. So even though I don't have any shares in Abaloparatide, nothing. I want that to develop by CMC Vellore. CMC Vellore. So academic conflict of interest nowadays people don't ask, but many new journals will ask you, do you have any academic conflict of interest? They won't say anything if you don't fill it up. Financial conflict of interest, we have to say no. Academic conflict of interest, we just have to say no. If you say yes, then obviously nobody will agree that I am. But these are, I think, supposed to be more playing a bigger role in the universities than financial conflict. Because it's very subtle. Yeah, I whole life I developed this kind of molecule. I want to see that going ahead. So I want to push that research. So there are subtle things which are not shown up in these. But as young people, you must be aware there are two types of conflicts: financial and academic. Okay, go on.
Next, we want to know if a procedure for updating the guideline is provided. So ideally, they should have provided regular updation intervals, or saying we will update this guideline in 2 years or 6 months. But that has not been provided. There are some general guidelines under NICE for updating recommendations, but again, no time interval for this specific guideline is provided. Coming to the next section, it is clarity of presentation. So the first question, are the recommendations specific and unambiguous? For this, we want to look at whether there is a statement of recommended action, there is identification of the intent or purpose of this particular guideline, the relevant population and caveats or patients to whom we will not apply this particular drug. Additional considerations are if there are multiple recommendations, is there clarity to whom each recommendation applies? Or is there uncertainty in the interpretation and discussion, and has that been reflected in the guideline? So again, I have downgraded it because this definite purpose has not been mentioned. They have written Abaloparatide is recommended as an option for treating osteoporosis, but what is the expected outcome? Is it quality of life improvement, reducing fractures? Not mentioned clearly. The relevant population has been given, caveats have not been mentioned. Even here they have written it can be decided as to what to give after considering the cost. But again, not mentioned that romosozumab cannot be given in patients with MI, teriparatide requires storage, all those. So not clearly mentioned in this guideline. Coming to the next, the different options for management of the condition or health issue are clearly presented. So they mentioned, they've given these comparators even in the guideline, other anabolic therapies like romosozumab, teriparatide, and they've given this table as to where abaloparatide fits in to the treatment diagram. So postmenopausal women with osteoporosis above the interventional threshold at risk of fracture, they classified it as high risk of fracture and very high risk of fracture. Ideally, very high risk of fracture, which is a fracture more than 60%, is where abaloparatide comes in. And again, with patients who are intolerant to bisphosphonates, can be given abaloparatide in the second part of the diagram. So they have mentioned the comparators, and the population suited for each is mentioned, but it's not very easy to find in the guideline paper. So I've downgraded by 1 to 6. Coming to key recommendations, are they clearly identifiable? For this, we would have liked the recommendations to be more catchy with algorithms, so that someone who is in a peripheral setting, he looks at the guideline on his phone, he would want to know whether he can apply it for his patient, rather than reading through all this text which does not give a proper picture to someone who wants to apply it. So I've downgraded it to 3 because the recommendations are not easily identifiable. Coming to the applicability. Here we want to know whether the guideline describes any facilitators and barriers to its application. So the facilitators are the NHS or the UK health system provides funding and resources for all the guidelines that are produced by them within 2 months. There is also a commercial arrangement where organizations can get this abaloparatide with a discount from the pharmaceutical company. So those are facilitators for its use. But barriers are, again, this is not clearly mentioned in the guideline, but when we look at few patient experiences, they have said that I am averse to injections. What about people with physical disability? I don't sometimes understand what drug my physician is telling me to use. So all these few barriers have not been clearly addressed in the guideline per se, and it's also again difficult to find in the text. They should have mentioned what are the barriers that people might face, how to tackle them for someone in a peripheral healthcare setting. So I've downgraded it by 1 again.
It's like English, other language translations. So this guideline was made in India, and it's only in English. Then 90% of patients may not understand, doctors may understand. And you must make sure that there is somebody in Hindi or Tamil or other language. Like that in UK, I suppose 99.9% of the people know English, so that may be a barrier. If somebody doesn't have internet, how will they ever access this guideline? The barrier will be people, naturally all the black people living in poorer areas, no internet, will never hear this drug. They will not go and ask a GP to give this drug. How does a GP sitting there know about this drug? They have to make sure that under the GP education, this new guideline will also add to that. This he may keep giving you what in 1970s he learned. So there's another way of this. There may be so many guidelines in general medicine. That's why German clubs are so important. Because we'll be practicing what we learn in MD. But what happens in cardiology is far different from that. So we have to keep ourselves updated. So they should make a way of this being available. Okay.
The next question asks whether the guideline provides advices or gives tools on how the recommendations can be put into practice. Again, the implementation section of this guideline is quite broad. They have not provided educational tools, or the checklists are whether there are guideline summary documents, whether there are any checklists or algorithms, solutions to barriers. So all this has not been provided. So it becomes difficult for someone or a GP sitting in a peripheral healthcare setting to easily apply this guideline to his practice. So I have downgraded it to 2. Coming to the next question, any potential resource implications of applying the recommendations have been considered. So this guideline, they have done a cost effectiveness and an economic analysis as well, and the health economist was also part of the team. But they have mentioned because of confidential commercial arrangements, they cannot mention the costs. So all this has been redacted in the documents. Also the exact health benefits cannot be reported as what they have mentioned.
Now we'll go back to that. So there's something to learn. It's not part of guideline, but you should learn how to decide. Suppose you have to pay, remember that we do NNT every Saturday, we learn NNT. Other way say that if Let us say the NNT for is 3 or 4 for the new drug, and the cost of the drug is 30,000. If the NNT is 3 and the cost of the drug is 30,000 for a full course, what is the cost of saving a life? Number needed is 3. To take one person, it is 30,000. If 30,000 and 3, about 90,000, roughly 1 lakh, you can save a life. So how do you decide if that is a reasonable amount or not? You may think 1 lakh is too much, you may think 1 lakh is change, peanuts. So there's an economic guideline, which is where there's an economist. There's something called GDP, gross domestic product of every country. But that's only for a huge country. Like for example, the GDP of Pakistan is X dollars. The GDP of India is also X dollars. But if you divide that by the number of people, GDP per capita, suddenly then GDP per capita of Pakistan must be maybe much higher, or Bangladesh is in fact much higher than, we laugh at Bangladesh, their GDP per capita is higher than India, even though our overall GDP is higher. The GDP per capita reflects how much money each person has got. So economists say that if one quality adjusted life year based on this treatment is less costly than per capita GDP, then it's cost effective. That's how they have, who knows why they made the decision, but they said that. So in UK, the $30,000 quality, actually the per capita GDP is in UK is probably 10,000 pounds. So if it is less, if you can get one quality adjusted life year from Abaloparatide for 10,000 pounds, it's very cost effective. So if you multiply the per capita GDP by 3, so 10,000 becomes 30,000. Then they say, okay, anything up to 30,000, the government will still consider it cost effective. More than 30,000, they say not cost effective. So that's how these cutoffs are made, and people say these are very arbitrary. There's another method of doing that, it's called willingness to pay. So how much will you pay for 4 wheels, an engine and a roof? What is that called? How much will you pay? 10 lakhs. But if it's got a Mercedes-Benz symbol on it, maybe 15, 20 lakhs. So when anybody markets anything in the world, they always do this. Survey it's called, but actually it's called willingness to pay. So when Mercedes-Benz plans to come to India, they do a survey of all the richer people. How much will you be willing to pay? And then they'll make a market sense. Our cost is 10 lakhs. People are willing to pay 15 lakhs. So we'll market it for 15 lakhs. We won't do 13 because they're willing to pay 15. We won't do 16 because nobody will buy it. It's called willingness to pay. And there's a threshold. You have to ask many people. So another way of doing this is asking the people how much are you willing to pay. The problem of putting an artificial threshold of 30,000 is 2 things. Everybody is now targeting 30,000 per quality. So even if the pharmaceutical company can sell it to you at 10,000 a quality, hey, we have got another 20,000 wiggle room. Let's mark up the price. Instead of 30,000 per quality, we'll mark it at 29 because everybody is very happy. But where you said 30,000, we are giving you for 29. Then they're going to usually market it for much less. So when you make this kind of artificial cutoff, people tend to play games with it. Or if their cost per quality is 40, they go to the statistician. Hello, can you do some adjustment? Can you leave out this data? Can you put that? Can you make this other analysis method and make it 30? So everybody starts manipulating till we reach 30. So the goal of every pharmaceutical company in UK is to hit the target of 30,000 pounds per quality. So it becomes a sort of artificial target. And then the whole guideline committee is also short. How do you said research is less than 30, you are saying more than 30. It becomes an artificial thing. So I'm just trying to say that now slowly you have to get used to where do these economic cutoffs come from. What's the benefit of having a cutoff? See, then you have a ballpark figure. Hey, you're marketing Abaloparatide. You're marketing some new myeloma drug. The myeloma drug cost per quality is 10,000. Abaloparatide is 30,000. Okay, we only have this much X budget. This year we are going to approve the myeloma drug. Remember what's the true cost of anything? What is the true cost of anything? If you have 5,000 rupees and you spend it on going to Mahas, what have you lost? What else would you have done with 5,000? I told him nothing, sir. I tried to make a phone call to my wife. What else would I have done with 5,000 rupees?
what is the cost of going out to Mars called? Opportunity cost. You only have X money, you spend it on this, you lost the opportunity to spend it on something else. So the health budget in UK is limited. So every country is limited, they don't keep on increasing it rapidly every year. If you're going to spend it on Abaloparatide, you're going to cut off something else. That's the opportunity cost. Ultimately, the country has to decide, okay, what are they going to take off? And that person won't realize it. All of a sudden, that drug is gone. It's not, you can see that clearly. They won't tell you, hello, we are giving this drug and we are stopping it. They won't tell you that. It will just reduce. So that's why we must make up this mind. I don't know why, but when they black out all this, clearly it's because it's probably crossed that threshold. So if it's less than the threshold, then tell you, yes, yes, you can see it there. So this is a red flag for anybody. Okay.
So they have said that the resource impact of implementing this recommendation would be less than 5 million per year, and it will be available to patients with a discount. What the committee has worded it saying that cost effectiveness estimates were within the range that NICE considers an acceptable use of NHS resources. So I have downgraded this to 5. Coming to the next, the guideline presents monitoring and or auditing criteria. So we would have liked to see that how do they evaluate whether this guideline is being used by practitioners or are patients getting this drug. For this particular guideline, there are no auditing criteria that has been mentioned. But NICE has overall auditing criteria which looks at policies, which the data source of which are local formularies, looks at audits where targeted clinical audits are done and patient surveys are done. So this is how for all its guidelines NICE does audits, but for this guideline per se, what is the frequency of auditing has not been mentioned. So I have downgraded this to 2. Coming to editorial independence. First question is, the views of the funding body have not influenced the content of the guideline. So this guideline, as we know, is developed by NICE. So there is a statement in the guideline development manual which says that NICE must recover its costs for producing technology appraisals guidance from the company that expects to market the technology in England. So in other words, the company has to give some money for guideline development, which is again why I have downgraded this to 2. Coming to the competing interests of the guideline development group members. In the minutes of the meeting that they've taken, they have asked all members to reveal their conflict of interest, and they have documented this in this particular document where they've described it as what is the type of interest, indirect or direct financial interest, what is the description, and whether they've displayed the interest. So all members did not have a conflict of interest, but the few members who had, it has been documented. So I have given it a score of 7.
That's a thing to know. If you want someone to be an expert on Abaloparatide, they likely to have worked on osteoporosis. They likely to know about teriparatide and its analogs. So it's very difficult to actually, you may find it difficult to find a group of experts who are interested in osteoporosis, know about the drug, but have not ever done a study on it, or don't have some conflict of interest. Because in the West, that's how it works. A doctor develops a new drug, then the pharmaceutical company tries to buy it from him, or he gets shares in that company because he's also part of the development. So, and on the flip side, you think there are thousands of doctors. You couldn't find 5 people who didn't have shares in the company, directly or indirectly. That's the flip side of way of thinking. You must always think, you make a guideline, and you're making for the whole country. You could find 5 Indian doctors who didn't have shares in Amgen or GSK or whatever. You could have easily done that. But here there, direct conflict of interest means I have shares in Abaloparatide. Indirect means I have shares in GSK but not in that division which makes Abaloparatide. So then why should you do all this? You could have found 4 other people. That's the way to think about it. Okay.
In fact, this person was a patient expert which was nominated by Royal Osteoporosis Society, who had a direct financial conflict of interest. Now coming to scoring the checklist, we have gone through all the domains, all 6 domains. Ideally, this should be done by 4 appraisers who give each. They've looked at only domain 1, and they're looking at 3 item scores in domain 1. They've scored it like this, and they take each domain score as the obtained score minus the minimum possible score divided by the maximum minus minimum possible scores and give it a particular percentage. So this is the percentages that I have given for domain 1 and each of the domains. 6 domains we have given a range from 50 to 70 for each of these 6 domains. Now coming back
What's
to
your overall assessment? No, you're good and okay. We're coming to that. Okay.
So coming back to our question, the 70-year-old woman who comes to our OPD, she is a diabetic with ischemic heart disease with a FRAC score of 70%. Would we consider abaloparatide is the clinical question? So based on this guideline, we have seen all its flaws and benefits. I would grade it as an overall quality of 4. And I would choose to adapt this guideline to our scenario. The flaws that were only English language studies were taken. There is a bias with the pharmaceutical company. I would like to take a search strategy and look for additional studies and redo a meta-analysis. The cost for this drug in India for this particular dose or 80 microgram is 862 per day. And it's not available freely, only this is a direct conversion from the NHS cost.